Hi, my name is Connie McClellan and you're watching a video on stereoacuity. Now, you'll recall from your previous studies that stereopsis is produced by the stimulation of horizontally displaced retinal areas, which fall within Panem's fusional area. And stereoacuity is thereby the measurement of the minimum perceived horizontal disparity. And so the smaller the stereoacuity value, the greater the stereoacuity, or the better the stereoacuity, because you can perceive very small amounts of disparity. As an example, if a patient has 200 seconds of arc being the measurement of stereoacuity, then that person has less stereoacuity levels than a patient with, say, for example, 40 seconds of arc. Now, in general, people with normal BSV should be able to attain about 40 seconds of arc. Some of our tests will go lower than that, will go down to approximately 15 seconds of arc, and some patients can achieve that. But generally, normal value should sit around 40 seconds of arc. Now, as part of this video, we won't go into detail with regards to every single test that we can do to measure stereoacuity, but we'll just revise and talk broadly about the various tests that can be utilised in measuring stereoacuity and the differences between them. Okay, let's start off with the random dot stereoacuity test. We've got two in the prac rooms. We've got the Lang and the TNO. The advantage to using a random dot stereoacuity test is that it requires the patient to be bifoveal and does not offer any monocular clues, meaning that if a patient has a small angle strabismus with subnormal binocular functions, then they should still fail this particular test. And specifically here we're talking about patients with a microtropia, that a patient with a microtropia who may actually have some level of stereoacuity will or should fail a random dot stereoacuity test. So it is actually a good test to assist you in confirming the diagnosis of a microtropia. Now, we talked earlier about the fact that we use the 4-prism diopter test as an indicator of a patient who has a microtropia, but that in some instances the 4-diopter test may give you an inconclusive result because some patients provide anomalous eye movements during testing or show atypical responses. So if, for example, you have a patient who has a cover test result that shows no manifest deviation, but shows that they fail a Lang or a TNO stereoacuity test, then you have to suspect that the patient might have a microtropia, because these tests rely on the patient to be bifoveal, and so a failure on these tests indicates that the patient is likely to have a manifest strabismus. Moving on to real depth, here we have two tests, the Frisbee and the Frisbee-Davis 2. The Frisbee being the near test, where we have the plate or the 3 plates of various thickness that can give us a range of stereoacuity levels that we can assess, and the FD2 or the Frisbee-Davis 2, which is the distance test, where we've got the opportunity to be able to push these shapes backwards and forwards. As a real depth stereoacuity test, this test can also be utilised to indicate whether a patient is bifoveal or not. And the final group of tests are those that are considered to be contour line. The main difference between these tests and the tests that we've talked about, random dot and real depth, is that contour line allows for monocular clues and permits a patient to not be bifoveal. So a patient who's not bifoveal could pass a contour line test. Now, a patient who is completely stereoblind, so as an example, let's say we have a patient with a 50 diopter right esotropia with right suppression who is stereo blind should fail all 3 types of tests: a random dot, a real depth, and a contour line. However, going back to that patient who has a microstrabismus, who is not bifoveal, will fail a test that relies on the patient to be bifoveal, such as random dot and real depth. But because they do have subnormal binocular functions, can pass a contour line. So this is the cohort of patients that you actually want to perform at least 2 stereoacuity tests. You want to look at whether they can pass or fail a random dot stereo test as an example, and then look to see whether they do have some level of gross stereopsis that's picked up by contour line tests. So the most commonly used contour line test is the titmus. The reindeer is not used as frequently, and the ram dot is a little bit different to the titmus and the reindeer in that it does actually incorporate both random dot and contour and does not allow for monocular clues. Now, there are some features about these tests that are common. One is that they both have a screening tool to look for simultaneous perception and whether the patient may or may not be suppressing. And you'll see here it's a little bit difficult, but there's a letter here and a letter here. And you ask the patient whether they can see the letter on either side, in which case you'll be getting an indication of whether, if they can see both letters, you've got simultaneous perception. If they can't see one of the letters, you've got suppression. The same goes with here. You've got an R and an L, and then you've got a cross. Again, if you see the R, L, and the cross, then you have simultaneous perception and no suppression. However, if one of those letters is missing and one of the lines, whether it be the horizontal or the vertical line that's part of the cross is missing, then you're getting an indication that you have suppression. So we have a screening tool to begin with in all these 3 tests. Then we have the opportunity to then begin to measure the lowest level of stereoacuity. And for the titmus, we have the fly, which is a very gross test, which equates to 3,000 seconds of arc. And then, depending on the age of the child, you actually have an opportunity to use animals and then circles as a more complex measure of stereoacuity. In terms of recording stereoacuity, we always record the smallest disparity appreciated by the patient. And so the simplest form of recording is to indicate the test performed. So here we have lag 1 and TNO, and then the smallest disparity appreciated. So 550 on the lag 1, and for the TNO, 30 seconds of arc. Now you can, if you like, actually provide more detail in your clinical notes and indicate what images, for instance, the patient saw. So here we have lag 1, and it's indicated that one of the 3 shapes was identified by the patient, and that this translates into 1,200 seconds of arc. For the titmus as another example, I mean, you could have just written that 40 seconds of arc was the stereoacuity length, but here the orthoptist has indicated the patient saw the fly, which is 3,000 seconds of arc. They saw all 3 animals, and they saw 9 out of the 9 circles, which then translates into 40 seconds of arc. Okay, that brings us to the conclusion of this video. Thank you for watching.